Well, thanks, folks, for joining. And we are starting our book club back up again this fall after taking a little bit of a summer break. This is chapter 29 of the 30 chapters in the Bouncebacks Critical Care book. And we are really blessed to have not only the chapter author, but also the section editor here today from our chapter. So I'm going to just let everyone know there are no conflicts. Everyone that attends will get an hour of CME. Folks can watch this later on the website, EM like emergency medicine, embouncebacks.com, and you're easily able to do that. I'm going to pop up our CME code for folks who would like to get some CME. This is our disclosure statement, and I'll just put that up for a second, and then I will put up the CME code. So for folks who want to sign your phone at that, you can get the 1 hour free CME that we include with this. So I'm going to just with the panel, maybe it'd be sort of fun today to let everyone introduce themselves. So Roya, do you want to just tell us, you are the chapter author, where you are from and your position there?
Absolutely. It is an honor and pleasure to be with everyone tonight. I am Roya Caloia. I am an emergency medicine physician and core faculty of our residency program at Henry Ford Genesis in Grand Blanc, Michigan. I'm also the chairman of the National Clinical Governance Board for U.S. Acute Care Solutions. It is a pleasure to see all of your faces.
Nice. Gavin?
Yeah, my name is Gavin Harper. I'm one of the chief internal medicine residents at Adena Health System in Chillicothe. I work with Jordan and Dr. Weinstock. Um, yeah, really excited to be part of this bounce back.
Nice. All right, Jordan.
Yeah, along with Gavin, I am one of the FM chief residents at the Dean Health System.
Jordan, I can barely hear you. I'm not sure if you're using like an external mic or not. Let's come back to you in just half a second here. And you might want to just fiddle around with that a little bit. I could hear you a little bit, so you're not muted, but couldn't hear you quite well enough. And then Joe?
Yeah, thank you, Michael, for inviting me again to be part of the Bounce Back webinar. Enjoyed the last few times. Yeah, I'm Joe Shiber. I'm a professor at University of Florida, Jacksonville. I for about first 15 years of my career, I did emergency medicine as well as critical care. Basically one FTE of both. So I wasn't part-time in either one. Unfortunately, that's how a lot of us combined people work. And so the last 10 years, I've done predominantly critical care. I'm a neurointensivist as well as an adult medical and trauma intensivist. And currently I run their ECLS ECMO program here in Jacksonville.
Nice. Awesome. And Jordan, I can introduce you real quick if you want, or did you get your mic working?
Testing.
Yes, perfect.
Yeah, I'm Jordan. I work with Gavin and Dr. Weinstock. I'm one of the FM chief residents at Adena.
Nice. All right, so let's just jump in with our case here. This is a 78-year-old woman with dementia and worse confusion. And I'm sure all of us had the experience of one of these staff members saying, I'm not sure why they're here. They have dementia. Aren't they always confused? And that's something we always have to fight a little bit against, right? Because certainly there are all different stages of dementia. Some folks, not that it's a great idea, are still driving, and some folks don't recognize the faces of their spouse or their kids, right? So this was the first visit, and we're going to focus on this just a little bit here. And I wanted to have a discussion on this, but then what we're really going to focus on, and that's the focus of the 4 Bounce Backs books of this critical care book, is the return visit. And that's the thing that's going to make a really big difference as far as we go into different decision points that we can make, use the literature to figure out where we go. We're going to see what the actual clinician did, and then we're going to have some more weighing in and after we find out what happened with the patient. So this is the first visit before the bounce back visit. So we're just going to spend a short amount of time on this. I'm going to briefly summarize it. Chief complaint is altered. Well, I'll tell you about her story first. Actually, I should do that. Esther was born in New York City, went to high school in New York City, married in New York City, and then started a family. From young adulthood to middle age, her apartment was filled with the laughter of children, relatives, and friends. But when her last son moved out for good, her life slowed, as did her cognition. For the last 8 years, and she's 78 here, so since the age of 70, she's had a progressive decline with a gradual reversal of the traditional marital roles. Her husband has stopped working and is now caring for his frail wife. On a steamy late July morning, with his wife more confused and starting to hallucinate over the last few days, David, that's the husband, decides it's time to seek medical attention. He helps his wife into an elevator, hails a cab. They go to an urgent care, but the PA there is concerned that this exceeds the ability of them to care at an urgent care. They give a urine, they do a dip, but the dip is normal, and so they direct the patient to the emergency department. So what you see in front of you is the emergency department documentation. 78-year-old female with acute delirium, and I'm not going to read the whole thing. Hallucinatory events and arguing with people that are not in the room for the last 2 days. She's had no urinary complaints, but the husband, and we can see how this might play in a little bit here, says that the last time this happened, when she had a worsening confusion, she had a UTI. She hasn't had any new medications, no falls, but she is on rivaroxaban, and she also gives additional history. It's had a couple weeks of shoulder pain. So the documentation of the past history you can see here. I'm not going to read that whole thing. Her blood pressure is a little bit soft, but 107/63. Her exam, alert and oriented _1, and they actually document that she knows her name and the month, but unsure the date or place. And then the musculoskeletal exam, decreased range of motion, no warmth over the shoulder. They say that her stool is dark, but not black. However, it is heme positive. She has some anemia, and they say she has evidence of upper GI bleed. And on top of the rivaroxaban, would be concerned about this. And so they started her on a PPI drip, and they admit her. So before we really go much further, I want to just sort of focus in on this. And the first question, Roya, I'm going to direct to you, because I'm just curious here to Gavin. I'm just curious here. What do you think about the history here? It's not bad, but is there anything that you'd like to see that wasn't here?
So yeah, this history, when someone comes in with altered mental status, it's kind of very broad differential. This person, is presenting, we don't know the baseline of what her mental status is. It doesn't mention anything about that. They don't really go into explaining what the shoulder pain's about. So it kind of leaves a lot of open, a lot of questions still with the HPI. It doesn't really answer why she's here, what her baseline is, and what's up with the shoulder pain.
Sure. And you think of it like a directed history based on what the considerations for the diagnosis would be, right? I mean, there's all kinds of considerations. We'll talk about that in just a little bit here. So Jordan, let me move to you next. And I'm just going to key in on one part, not of the history, but of the exam. And I'm just going to read the neuro exam briefly. No lateralizing weakness or numbness, no facial droop, no dysarthria. Now, it's a little bit hard to Monday morning quarterback it. I know you weren't a fly on the wall, but what do you think about a patient with confusion, obviously neuro symptoms, and this neuro exam?
Well, that neuro exam appears to be one that was taken at the doorway, no real detail in it, very bare bones. Anybody with a neuro complaint does need a detailed neuro exam, cerebellar testing, see if you can evaluate their gait and so forth, especially given her history of dementia. That just highlights the need for a more thorough neuro exam to evaluate for future deficits as they may arise.
Yeah, totally agree. And I tell you, I've been saved so many times when I have a patient with dementia comes in from a nursing home, usually on Sunday at like 12:30, and you call the person at the nursing home, which I try to do that routinely, and they say, oh, we didn't send her for confusion. She's always confused. We sent her because she fell of it and has left hip pain or whatever, right? So, focusing on not only just the history, but the exam, what's different about this confusion? And then, and I'm guilty of this also, look, my macro might say, head normocephalic atraumatic. It's sort of lame, right? However, I'd like to think that when a patient has abdominal pain, I push on their abdomen. I'd like to think when a patient has a neuro complaint that we actually do a more focused type of neuro exam to what their complaint is and document it in that way. Alert and oriented ×3 is okay. Alert and oriented ×3, the patient easily and readily knows the day, month, and year is much better. Not in this patient, of course. Okay, so Roya, let's get to this thought that the husband had about the UTI. And it's so easy to see how we can be led into this. You have a couple of white cells, a little bit of bacteria. Yeah, she's got a UTI. Let's give her some antibiotics and send her home. But what does the literature really show us on UTIs and confusion?
And first, I'd like to say that I think every single shift I work, there is some family member who swears the UTI has caused these exact same symptoms before. But really, there's nothing. There's nothing that shows direct correlation of a urinary tract infection causing confusion. What we do know in elderly patients is that maybe the urinary tract infection causes some dehydration, so they're not drinking as much. And then maybe that's what's causing an electrolyte abnormality that's leading to delirium, especially in our patients with some baseline dementia. So there's usually more to it than just this urinary tract infection. It's nice. It's really great. You can tie it with a bow, call the admitting team and get them admitted. But more often than not, either the urine's probably not a great sample. Maybe we're saying that it's on the periphery, could be a urinary tract infection. I would implore everyone that's on the call to really do a deeper dive, because it's not usually just a urinary tract infection, unless they're like super septic, that's causing this confusion. And it's usually the sepsis that's then causing the delirium and confusion for people. So, unfortunately, as many times as patients will say, this happened exactly the same the last time and it was a UTI, more than likely the patient was dehydrated last time too. They got some fluids and that's really what improved them, not a bunch of antibiotics. So unfortunately, the literature does not support our patients' families' claims.
And it sort of seems like the UTI of the elderly is like the otitis media of children or the acute sinusitis of adults, right? Easy to sort of pin it on that. And, maybe usually be right, or maybe usually it just is some sort of self-limited viral process that's not going to burn you. But got to be really careful, patients with catheters, it's really the symptoms they're having, not actually what you're seeing when you do the urinalysis. Okay, so Joe, I'm sorry you've been quiet this whole time. Wrap this in a bow for us. We've got a patient. The blood pressure is sort of soft. She has dementia with worsening confusion, black tarry stool, and a minimally low hemoglobin. What do you think as far as just getting her admitted? What could we be missing? Bring this home for us.
I think, first of all, most people already mentioned it, but just to make sure that we all have the clear definitions between dementia and delirium, and the fact that, of course, a patient with dementia can also have delirium. So you can have both at the same time. But I also completely agree with you, Mike, in that it's so important to say, what is this person's baseline? And so to reach the nursing home or a home aide or a family member who knows the patient quite well. We also have all had the experience of on holidays when family sees an elderly person that they haven't seen in a year, and oh my God, you look terrible because I haven't seen you in a year. So, they used to be out playing basketball, and oh, well, that was a long time ago, and they used to be long. Okay, so but to have a recent someone that's reliable that can say what they've been doing, and so that this is either a change or not a change, and of course, agitation or hypo. Not necessarily always hyperkinetic, but hypokinetic delirium. So that does not usually go with dementia unless you're at the end stage of dementia, where you've actually you've lost the ability to be independent at all. Besides that, remember, we have to always look for someone who's having an acute problem on top of their prolonged slow-moving dementia. Also, with a GI bleed, remember or any hemorrhage, the initial hemoglobin is not reliable. You can have a hemoglobin of 14 and open up your brachial artery from a laceration on a plate glass window and be in category 4 hemorrhagic shock. And within minutes, and your hemoglobin will still be 14. It will not have dropped. And so either you replace that person's lost circulating volume with a non-red cell containing or non-whole blood containing, so with crystalloid, or if the person doesn't die from their hemorrhagic shock, they actually will slowly recruit extravascular interstitial fluid into their vasculature. And so until then, you won't see actually drop in their hemoglobin. So just recall that. So the hemoglobin, the quote, doesn't look so bad if the person just passed 3 large, not just melanotic, but maybe bright red blood, per rectum, or massive hematemesis that just occurred. So just always take into account the clinical scenario and not only the hemoglobin. I typically would say this person who has these signs and symptoms, they're going to get admitted, of course. In any older elderly patient, you just have to be much, much more conservative. Your threshold has to be very low to admit that patient, as well as being honest when you call your consultants. When they say, well, nothing sounds that bad, you say, yeah, but the constellation of everything together in this elderly patient puts them at high risk of having something bad happen. So even though I can't tell you the exact thing that I think is a potential life ender right now, there's enough things together that I used to kid and I used to say, why are you admitting them? Because I'm ruling out my next M&M case. That's why.
Right.
You know, because that's what happens when you send home a geriatric patient with a lot of vague signs and symptoms that doesn't look great, is that they're going to come back with something really bad. So even when you're not certain, say, you know, really, and when you're honest with your consultants, they appreciate that. Instead of trying to fluff it up into something it's not, just say, I'm just concerned. Things aren't exactly fitting together, and someone that I think is a very safe person to go back to their current situation. So please, you know, acknowledge that, and, you know, and if within a 24, 40 hours, if everything looks better, then great, we're all happy. But we don't want this person to actually have a worsening of their condition, or God forbid, actually come back in and arrest. So I usually think that that's a good way of handling it.
Joe, I want to emphasize something you said just a minute ago. And to me, it feels like, look, you know, with all of the tests that we have available to us, with all the tests we do all the time, in the end, some of the more serious stuff is really a clinical diagnosis, right? And exactly like you're saying, don't wait for the hemoglobin in a patient who is exsanguinating, right? You know, Mies and Swami talked today at the beginning of the MRAP episode about a patient with adrenal insufficiency, and that being a clinical diagnosis. Give the steroids, you know, in that patient where that's a concern. You're not going to have to wait for labs to come back, or an necrotizing soft tissue infection. You know, that's a clinical diagnosis. Don't wait for the result of your imaging on that. So before we get out of this case, 'cause I want to get to the really probably more exciting stuff with this case.
Mike, can I make one last? Can you make one
Oh,
last
of course,
comment?
yeah, absolutely. Go ahead.
I couldn't agree more on what you were saying, and that is part of the issue. Unfortunately, with the way, again, I have no issue with scoring systems and other ways to actually document the risk of things, but clinical judgment, clinical gestalt is so important, in that it's something that actually it's harder to quantify. But we all know, because of other studies, that a seasoned clinician actually scores the same or better than any of the other scoring algorithms for suspecting someone has ACS, for suspecting someone has a PE, for suspecting somebody is going to require MTP with trauma. And actually, I published something about 2 years ago that showed that the gestalt of saying whether someone is just critically ill or injured actually scores very well with actually what their outcomes will be. So just saying, I think this person's sick or not sick, which we do very regularly, that yet, yes, seasoned clinicians are quite good at doing that. And I think we shouldn't devalue the value and the judgment of that.
So in just a second, we're going to look at a literature review. And if you look at the medical decision-making, the patient is taking a leave on top of the rivaroxaban. We're going to look at that literature study by Davidson. But before that, Roy, I know this wasn't part of our formal format, but you know, you are obviously teaching EM residents. What is your thought on how you balance with them things like scoring systems, like Joe talked about, and the confidence to be able to make a diagnosis clinically just on your bedside evaluation?
Excellent question. And it's something we tackle regularly as the resident grows through the program as well.
Mm.
All of the tools really depend on your clinical gestalt, right? And the majority of them that you end up utilizing incorporate your clinical gestalt. If you think about the heart score, for example, what you think of the patient really changes it from a 3 to a 5 or a 3 to a
Right.
4. When you think about Wells, you think about all of that really takes into account a lot of what you know. And so I really harp on it. And if you ask my residents, I'll probably say the same thing, but it's really what you see at the bedside. It's what you've learned and what you continue to learn that makes all the difference, and applying those tools. There are tools out there to help you make maybe less risky decisions so that you can practice better medicine. But ultimately, they all start with the fundamental and the important part, which is your clinical gestalt. And you have to develop that and continue to cultivate that, because without it, you can have all the tools, but you're going to be like an automaton, and you just click, what here are your problems, and this is the algorithm you go to. So those tools, I think, are good as long as you understand that you need your pretest probability, you need your experience and what you think about the patient to truly help the tools help you. They are not standalones. I couldn't agree
Yeah, and
more
I'm
with you,
so glad
Joe.
that you say that. I'm sorry, go ahead. Yeah.
No, I said I couldn't agree more with Joe. I
Yeah.
think 100%, I'm on board with
And
that.
And it's really the fun part of medicine, honestly, to me. The patients that I enjoy, especially the more critical ones, is when you're able to do something just on your bedside evaluation. I mean, like, no one went into medicine to refer people to specialists. I mean, that's not what we said at our medical school interview. Okay, so Gavin, you've been very patient. You have prepared just like a brief review of this study here. It's pretty interesting by Davidson, and they looked at patients taking who are anticoagulated who then were taking NSAIDs or aspirin.
Yeah, so looking at this article by Davidson, kind of splits things up with like clinically relevant bleeding versus like major bleeding risk. But looking at it with like direct oral anticoagulant use and then using like an aspirin NSAID on top of that, your risk of major bleeding is almost 2.4 times higher using them both together. Um, it's going to be a higher rate, almost 2 times more. So just kind of looking at that with just using oral anticoagulation alone. So very significant numbers here from the study. So it kind of just shows you the risk of using any type of NSAID. It doesn't really talk about like selective COX inhibitors, just COX-1, COX-2. So it doesn't really differentiate that, but really shows the significant risk of bleeding with those.
And you think to yourself, it's like, okay, you have a shoulder strain or an ankle strain. I mean, no one's life was ever saved by some ibuprofen. But even though the overall risk might be still fairly low, boy, 2 or 3 times higher is still pretty significant. Okay, so what happens with our patient? Not surprisingly, she gets admitted, she gets discharged, and she and her husband fall back into their previous routine. She wakes up late, he fixes her breakfast, they have a mid-afternoon lunch and a visit from the children. However, 4 days after the hospital discharge, she's not up. And when her husband goes to check on her, he finds she's fallen. He's unable to get her to stand, calls 911. When the paramedics arrive, she is purplish and diaphoretic, barely responsive, and she has slow respirations. She becomes bradycardic, and then she decompensates into full arrest. She's transported then to the emergency department. And this is her documentation upon arrival back to the emergency department. So what we're going to do is we're going to do 3 different decision points on this return visit, and then we'll talk about different teaching points and hopefully things that we can all take to the bedside of our next shift to change things and make patients safer. So history of present illness, patient comes in. I did see the patient immediately upon arrival, spoke with the paramedics. She can't give any history, and they talk about what the paramedics did. They gave 2 milligrams total of epi, 2 of sodium bicarb, got a pulse back, and she does have a pulse and blood pressure. Again, low-ish on the side, 94/69, and she's sort of tachycardic. And so they get an EKG, shows AFib with RVR. They're calling it, it's 108, so technically it is, but probably not what's causing her symptoms at this time. And they spoke with the cardiologist, and they felt that this was not from a STEMI. So what we're going to do is here, we're going to go through and talk about some different discussion points here. And Roy, I'm going to start you back on the beginning here again. This patient is post-arrest. We know that she'd had this GI bleed. We know she has dementia. We know she has fallen. What do you think are some of the more possible etiologies of the arrest? Because, of course, considering what could be going on as a diagnosis will sort of direct what we're going to do as far as our initial data gathering and management.
Absolutely. So this is my favorite thing to do, going through our differentials. What could be going on with this patient? Is she hypovolemic? Like going through your H's and T's, did she have more profound blood loss? Do we know anything about it? Is she hypoxic? Did she have a thrombotic event because she was held on her rivaroxaban and she has this history of AFib? Did she get it restarted? Did she not get it restarted? I have so many questions. Is she septic from something? Could she have caught something while she was in the hospital? She's got a horrible pneumonia. Does she have a massive PE? Does she have an MI? I think there's so many things that could have potentially happened to her. Those would probably be my leading things, some sort of a thrombotic event, potentially some sort of infectious process, or bleeding. Right? She was just here for bleeding. Could that have continued and to the point where now her hemoglobin's 4? Who knows? That could certainly cause her to be in cardiac arrest too, and slightly tachycardic, and hypotensive. So those would be my leading diagnoses. I would go through, other things. If I didn't know her history already, could she have taken an overdose of some sort of medication? Is she taking her husband's medications? They're both elderly. She does have dementia. Was she truly back to herself? Did she fall? Did she injure herself? Did she have a brain bleed? She was taking NSAIDs. She was just recently in for bleeding. So I would want more questions, and I would want some more information.
So certainly it sounds like you are going to do a head CT. Obviously, she fell. That's sort of a no-brainer to do that. That could have been the etiology of her symptoms. If she was like coagulopathic or, she could hypocoagulable, she could have had that from the bleeding that caused the bleeding, 4 to 6 days previous, and then, bled into her head for some reason, or it could have been from the fall. We talk about the fact that it could be a clot, right? If they stopped her rivaroxaban. On the other hand, she just had bleeding. So, I mean, your differential is huge, and I love all those things you're thinking about. Now, we're going to get some further testing, and it looks like she does have ROSC. So, Joe, there's been so much that has changed. I mean, I just use as a funny example, when I, like in the 90s, was in medical school, there was this sort of like MONA mnemonic for chest pain patients, like morphine, oxygen, nitrates, and aspirin. And now basically we don't do any of those things. I mean, I guess we give aspirin, but it's not a thrombolytic. Certainly it's an antiplatelet, right? But so much has changed with post-arrest care also. Can you give us just like a bird's eye view, a minute or two on how things have changed, and what are some of the initial things that you're going to do when this patient arrives in the ED?
Sure. Post-resuscitation.
I know that's like a 2-hour lecture, Joe.
No, I'll keep it quick. Post-resuscitation care. The most important thing is just as our other panelists mentioned, is that we want to identify what we think as quickly as possible caused them to arrest in the first place, because achieving ROSC is the first step to saying, now, how do we prevent this person from dying again? So quickly going through a rapid algorithm, I think what the main thing that we've gotten better with in recent time is that at the bedside, we can do most of the tests to quickly rule out the life enders. Between your physical exam, bedside x-ray, and the bedside point of care ultrasound, we can do a pretty good job ruling out things such as tension pneumothorax, and of course with the EKG, overt STEMI, free fluid on a fast exam, looking at the aorta to think if they have a AAA, and then right heart function versus left for massive PE. So we do a pretty good job, at least thinking about ruling in or ruling out a lot of the life enders. So that, I think, is one of the big advancements than having to wait to send someone off into a lot of other places to try to come up with potential etiologies of their arrest. Because if you don't figure out why they died, they're going to die again. So that's a big thing. I may be dissenting from others here, but I think targeted temperature management is still a foundation. There's never been a study that showed that temperature management was worse than allowing the person to be normothermic. There's been numerous studies that showed that it's better. And so I think 36 degrees for everybody post, and in selected patients that actually are younger, may have had maybe a neurologic event as the beginning, or a specific cardiac event. And if they don't have other contraindications, I will still take selected patients down to 34 degrees. I always bring back to the fact that we all know the physiology of how deep hypothermia works. Again, I work as a cardiac intensivist, and part of my job, and we do circulatory arrest, meaning we stop the person from having any heartbeat at all, and no circulation to their brain. If you're doing an aortic root replacement, where you actually are, not just a cabbage. I'm talking about someone that has a aortic root issue, and so for about 60 minutes, their temperature is down in the 20s, with no blood to their brain, and then afterwards we warm them back up, and they're most of the time unscathed as long as they haven't had an embolic event. So hypothermia works. We also know about, of course, people that get cold water submersions, cold water avalanche. And again, the most important thing about those events is that you cool down before you arrest. If you arrest and then get cold afterwards, it's not as effective. So it does show that the time frame is very crucial. And so if you can get the person's brain cool as quickly as possible without inducing a lot of iatrogenic issues, I think it's very worthwhile. Now, one of the main indications, if someone actually is actively bleeding, coagulopathic, or hemodynamically unstable, those things take precedent. And so working on those instead of trying to cool the person, because there are some, even going to 36, if the person is normothermic, inducing some hypothermia may cause some hemodynamic changes. So I would not put that as the top priority in this patient. I would definitely work on finding the underlying cause and trying to achieve hemodynamic stability.
Gotcha. And certainly preventing hyperthermia is a good idea.
Of course, absolutely.
I think we'd all agree on that one.
All studies show that you have to avoid having the person have an elevated body temperature. But the last thing I'll say is that the brain is generally 1 degree Celsius higher than the core temperature. So if you allow even normothermia of the person's body and they're 37 degrees, the brain is 38 degrees, which is already above the threshold for having hyperexcitability and damaging. So that's why even mild hypothermia of the core temperature, I think, has shown benefits.
Gotcha. So excellent. So Jordan, you actually have prepared some a discussion about a different study. Now, you would think, and many years ago, and I think we all sort of know because there's now 3 different studies that have looked at this, and probably even other ones that I'm not aware of. But you'd think, hey, heart attack kills a lot of people. If someone arrests, why don't we just treat them for a heart attack? But if you don't have STEMI findings on the EKG, it's not really quite as helpful as you'd imagine, as far as doing an emergent cath.
Yeah. So in 2019, the New England Journal published the COAC trial. It was asking if there were improved outcomes after out of hospital, non-STEMI cardiac arrests. They were seeing if patients did better with survival and overall hemodynamically, if they had an immediate coronary angiography after neurologic return, or if they delayed or were more selective in those patients. The results kind of revealed that either one is similar, both with survivability and overall hemodynamic stability. So it is recommended that if they are sans STEMI, you can delay it, be more selective with who you do your PCIs on.
Awesome. Okay. So Joe, I'm back with you here. This patient has, and I think we'll all sort of know a little bit the answer to this question, so we could probably do it fairly quickly. The patient has AFib, I mean, technically RVR. Her rate is 108. And I was just going to, before I even ask you that, this is that Day-Caudill study that was on that previous slide. And you're right, I don't think it showed that there was harm with this. This was one of the ones that I quote sometimes as far as the hypothermia. I just wanted to sort of put that up. But at any rate, this patient has AFib and her heart rate's a little bit elevated. How does that factor into your management? Or is it more just like you think that her tachycardia is a response to the underlying process?
Yeah, great point. So AFib is a little wild card for that circumstance, because if that was sinus tach and this person was in septic shock, you'd expect them to have a compensatory tachycardia, right? I always say it's much more worrisome if I see someone in septic shock, and again, where the shock indus does not help you, because if they have an appropriate bradycardia when they should have a tachycardic response, it actually is misleading and actually is much more uncompensated. So for AFib, yeah, the heart rate's 108. As you said, that is not causing her the problem. It would have to be much faster than that to say that would be the primary cause of her hypotension. So if she does have a diagnosis of AFib, and of course there's numerous categories: paroxysmal AFib, chronic persistent AFib, prolonged persistent. So it may be that you're not going to be able to do rhythm control on this patient if she actually is a long-term remaining in atrial fibrillation. The best you could say is, well, if the heart rate did become elevated to a point where I thought it was causing a problem, we would simply be using rate control. And then what would be the choices? Well, you have really three choices. You have beta blockers, calcium channel blockers, and digoxin for rate control. Amiodarone is really rhythm control, although because it's a mixed class drug and it has some calcium channel blocker and even some beta blocker effect, along with a sodium channel rectifier and all that, it's a very mixed drug. So that's why it's much more of a rhythm effect than a rate effect. I would never use a calcium channel blocker in somebody who already is hypotensive, because those medications aren't just AV nodal blockers. They actually are direct vasodilators, so you can expect to have much more low blood pressure with that. A beta blocker, using it in very small titrated increments, would probably be what I would use in this patient, trying to achieve rate control. And I'm relatively old school, but I use it to my advantage in that I often will start a small digoxin IV load with my beta blocker. Digoxin doesn't work quickly, but is the only AV nodal blocker that does not cause hypotension. If anything, because of its positive inotropic effect, will actually give you not a reduction in blood pressure. And so I will use that with my beta blocker to try to lower the dose of my beta blocker so that I get a decent rate control while preserving my blood pressure.
Yeah, I can't say how frequently in the 90s I used digoxin, and certainly not nearly as much anymore. However, did recently use it with a good effect. Okay, so Gavin, last question here. There's word that she's no code. How do you balance in some type of critical care type of situation that consideration that you don't want to do something against the patient's wishes? On the other hand, the fact that she is just post-arrest and someone else did resuscitate her.
Yeah, it kind of leaves us in limbo there for a second, trying to figure out, what her code status is. But, you can't really go on hearsay in medicine. So you have to kind of verify what her code status is. So, talking to the next of kin, which sounds like it would be her husband, whether that be a call on the phone or seeing him in person to make medical decisions, because she's obviously not able to. But I would still treat her as full code, even though as of right now, because she's already got resuscitated, and I would not stop my resuscitative efforts just on hearsay.
Yeah, I think you're exactly right. You have to go with the more intensive. That's the thing. You could always withdraw care, right? But if you don't initiate care, that's hard to sort of come back from that one. And, the paramedics did that. Now, I've had paramedics who have coded patients who have like a DNR bracelet on, or, DNR paperwork. Maybe they say, oh, well, it wasn't signed, or just the family member told them. And maybe I'm too liberal with this, but if there's a family member there that's a spouse and they tell me the patient's wishes, boy, I just find it hard to imagine someone's going to try to get the insurance money by waiting for their loved one to, or maybe not their loved one, to arrest and then try to get it that way. That's probably not the best plan to retire in the Caribbean, right? So at any rate, this situation, she's already been resuscitated. And of course, we have to continue until a family member gets there. But certainly that might be a discussion to have. And like Joe talked about earlier, well, whatever caused her to arrest, if you don't address the underlying problem, she's going to arrest again. On the other hand, if she gets a no-code status that we learn about, and she does arrest again, maybe we could be more closely able to follow what her actual wishes were. And I just put this up here. This just fairly recently came out last year about patients after cardiac arrest from the AHA. I think it's a little bit more for critical care settings as I read through it, but I just wanted to put that up there in case anyone is interested in looking at that. Okay, so what happens with the patient is she gets initial measures. Her blood pressure now is lower. Roy, I think you mentioned sepsis is one of the considerations. I'm not saying that she is for sure, but she's certainly febrile, 101.1. And then the medical decision making, I did go back and check on the patient again. She's hypotensive. The pressure is 64, gave IV fluids. Troponin is minimally elevated. This is the conventional troponin. Other labs are pending. This could be from a PE. Her husband's on the way here. And Gavin, as you were saying, we're going to discuss code status. So she's completely unresponsive, has not received any sedation medication. So let's sort of go to our next set of questions here, our next decision point. And Joe, I'm going to start with you again here. She's hypotensive. She was in the hospital less than a week earlier with what sounded like a GI bleed. Would you give blood empirically at this point, or would you at least wait until a hemoglobin came back in this situation, or would you do some sort of assessment, like, just look at her and see if she looks pale or see if she's actually bleeding from below?
Yeah, that's a tough one. If you knew the person was having a GI bleed before, again, I would have a relatively low threshold of having some evidence, though, that the person was either, if the husband said, oh, she passed some dark stool, or, anything by history. If she looked severely pale, yes, I would potentially use that. Or on a quick examination, if there was any stigmata that she had had recent bleeding. Short of that, it's kind of hard to just empirically start giving blood to somebody, since, there is some downside to that. There's always some, obviously risk of transfusion reactions, and blood's a relatively precious resource. But if there was anything that led me to believe that, yes, this was a acute or even, ongoing subacute bleeding that led to this, then yeah, I would have a low threshold to give her some packed cells or a unit of, again, I wouldn't start MTP. I would probably start out with 1 unit of whole blood or 1 packed cells and see what the response was, that while I was gathering some more data, because again, it looks bad if you discover someone has a hemoglobin that's very low or is really profoundly hypovolemic after they've been with you for a while, when you could have done something earlier. So I would probably try to work pretty quickly to determine that. But yes, I would likely, if I had any reason to think so, give some blood.
Gotcha. Okay. And then Roya, your question is, the patient is febrile. She's hypotensive. I guess it's probably maybe sort of an easy question, but antibiotics at this point, and what would you give?
I would, and I would go vancomycin. She was just in the hospital. She's got a fever. Is it hospital acquired pneumonia, hospital acquired anything? I would go broad spectrum to start. I would like to go back to the previous question about starting medications for AFib with RVR at a rate of 108. I don't think that's my primary thing that I'm most concerned about. I would resuscitate some more, especially with the nature of atrial fibrillation, and then see where she was, and then make the determination for rate control, especially with how hypotensive she was. Then too, with a rate that if it was 170, 100%, I would definitely be intervening. But at 108, just got there. I don't know that I would do that at that point in time, but certainly later. And I would agree with all the comments that were made about the right agent to make. For this question, for fever, I would. I mean, does she have a urinary tract infection now? Did she have a Foley while she was in the hospital? And there's so many things we don't know, that I would start broad spectrum antibiotics, especially in the setting of a temp. Could it be reactive from everything that she's got going on? If she arrested, potentially, but until proven otherwise, I think I would.
Awesome. All right. So Joe, I'm back to you here. Vasopressor medications. Maybe at this point you're giving, just say blood or IV fluids, one of the two, right? And, hypothetically you give those and she's still profoundly hypotensive. Certainly her MAP is way under, well, I should say her MAP is under 65. Her systolic is under 65.
Yeah, sometimes you even actually do 2 things at once if you think it's that critical. So sometimes starting volume and a little bit of a drip of a vasoactive, and then that way you're not waiting only for one or the other. And then as things go well, you can actually pretty quickly get off the Levophed or whatever your pressor of choice is. Remember, younger people again deal with with lower blood pressures much more forgivingly than does an older person who very likely doesn't have the ability to auto-regulate their cerebral vasculature, so much more likely to have a watershed stroke, much more likely to put that person into acute kidney injury, their organ failure. So you really may have to actually defend a blood pressure, more aggressively in an older person. So giving a volume and a pressor at the same time sometimes is necessary. And then which pressor? Yeah, I think this is probably septic shock. I agree with the other panelists. So probably Levophed, as long as the heart rate's not, reasonable to begin with. If we started Levophed, and even though you wouldn't expect it, but if the AFib rate shot up, meaning even the less prominent beta effect of Levophed compared to epinephrine, but if it still was pushing the heart rate higher, then maybe you would use neosynephrine as a standalone. But probably I would have Levophed as my initial pressor.
Gotcha. So in just a second, I'm going to give you the results of a bunch of her labs. But before we do that, and Roy, I was going to ask you a little bit more in depth about PE. I think at this point, probably most of us agree this is, at least a consideration for septic shock. But there are other considerations too, especially, for example, if the rivaroxaban had been stopped. Can we just have a quick, yes or no in the interest of time? Roya, send the patient over to CT scan for a CTA to look for PE, or just treat now and see response to treatment? PE
Michael,
study,
I
yes
feel
or no?
like I would not send her anywhere in the state that she's in. Feel like you're setting me up for failure. But I would use a rush exam, right? If we're
Yeah.
looking at it, there are tools at my disposal that I can do at the bedside to evaluate for that, and be able to see if I do need to go down that road.
Gotcha.
So that's
All
my
right.
quick yes or no.
Yeah, I love that. Gavin, PE study, I already saw you nod no, so I ruined the surprise. What do you think?
Yeah, I'm gonna go against taking her to the CT scanner. Just kind of my rule number one in internal medicine: never take an unstable person to the CT scanner. So I'm gonna say no at this point.
There's a reason they call it the donut of death, right?
That's true.
Jordan, do you agree with these other folks?
Yeah, it's a big negative for me.
Okay, and Joe, I'm guessing you agree also?
Yeah, correct. The person's too unstable. Unstable people can really only should be going two places ever, and that's OR or IR. And those are places to actually achieve stability, where you're going to determine, the interventions, not a diagnostic. So you never can take a person for a diagnostic procedure when they're unstable. That's actually a fool's errand. And as you said, you don't want to be coding the person in the scanner. That's a terrible thing to have happened.
Okay. All right. So what happens with the patient? And here's a lot of information we have. Our white count is high, sort of going a little bit more with the diagnosis of septic shock. Her hemoglobin is a little bit lower than it was 9, now 8.4. Hard to say if it's on the way down or this is just what her hemoglobin runs at, right? It looks like she has what we think probably is acute renal failure at this point with a creat of 3.8. She got 3 liters of fluid. Her blood pressure systolic is now 44. They waited longer, I think, than our panel would have waited to start her on Levophed. And they spoke with the husband, who said that she should be no code, doesn't want chest compressions, but he wants to keep her on the ventilator. So we sort of now are needing to follow the pathway that was started by the paramedics. I mean, that's just sort of where we're at with things. So this physician who saw the patient at 12:07 also agrees, I think, with all of us at this point, doesn't have significant anemia, which required transfusion. She's febrile, and they have started her on vancomycin. They put Levaquin on also. I don't think that's going to cause a whole lot of problems. And so let's get to our last set of questions here. We have 10 minutes to go. Wanted to save some time for some closing thoughts also. And of course, anybody who wants to weigh in, there's a lot of experience on the call, I'm sure, with anything on the chat. Feel free to do that if you have questions for the panelists. So let's talk at the beginning here. And Joe, I'm going to come straight back to you with this. The patient, let's just say, is maxed out on Levophed and is still hypotensive. Which is your next vasopressor of choice?
If Levo is maxed, or even before, theoretically, even before Levo is maxed, But if they seem to be a little resistant to levofed by itself, that's where obviously literature states that most people probably are comfortable adding vasopressin to the levofed. It's a different mechanism. Again, people in septic shock already have high catecholamine levels. So to use a non-catecholamine agent, vasopressin receptor as compared to beta and alpha receptors, I think makes physiologic sense in the literature would support that. One comment on this case's management. So dobutamine is a vasoactive medication. It is not a vasopressor. It's an inotrope but a vasodilator. It's a beta-1, beta-2, has no alpha effects at all. And so beta-1, beta-2 will cause increased heart rate. So a chronotrope, some inotropy, but unfortunately it's a vasodilator. So it is not to be used in septic shock. So if person needs increased inotropy or chronotropy when they're on levofed, you'd be in septic shock, you'd be adding epinephrine, not dobutamine. So that I think is an error here and would expected it to actually cause lower blood pressure. Ongoing hypotension when their volume is, you believe, reasonable, and you had them on at least, again, 2 pressors, levofed and vasopressin. Now you're in the category of so-called pressor resistant shock, and that would be where you would add hydrocortisone in septic shock, either 100 milligrams up front or 50 milligrams Q6, but 200 to 300 milligrams a day. It does help with getting the person out of shock. There's probably some hint or trend towards a mortality benefit in many studies, but it has been shown to actually reduce the time in shock. So I would do that. And then after that, you're then talking about maybe rescue treatments for high levels of nitric oxide, which is the baseline cause of distributive vasodilatory shock. And then you're talking about either methylene blue or hydroxycobalamin, but I don't think we have time to go into those details now.
Right. Yeah. So Roya, and then I'm also just going to very briefly, Gavin and Jordan, if you guys want to give me like a 30 or 40-second thought at this point. This patient, I think we all agree, probably has septic shock at this point. Her lactate's 13.4. What is your thought, Roy, here? And then I'll ask also Gavin and Jordan a couple, just for a very quick thought, and then we'll go to our summary of the case for all of us here.
I think the question for me was, could the hemoglobin be falsely reassuring due to dehydration? 100%. I mean, her creatinines bumped significantly from the last time she was here. Hemoglobin's actually lower than it was last time, and she's significantly hemoconcentrated. Her bicarb's 10. So I do think that this is likely a much lower hemoglobin than what we're seeing, and it's just falsely elevated because of the hemoconcentration.
And then I'm guessing along with that, if that's one consideration, right? Well, maybe that makes that consideration of giving her blood, especially having hypotension with the pressure systolic 44. Boy, it seems like this patient is certainly pre-arrest. Jordan, what are your thoughts? Just a real brief, like 20, 30-second bird's eye thought.
So we're looking at septic shock. We got to get our levo on, got to get the antibiotics, do everything we can to optimize the patient as best we can for success. That means we got to give blood, even if we have a slight inkling that she may be anemic. Even with the concentrated hemoglobin, I think we should. Sans that, I think that's about all we got.
Okay, Gavin, any further thoughts on this? Do you think we're pretty good with where we're at? And then we'll get a summary from all of us at the last few minutes here.
I kind of do have some more further thoughts on this. If we're escalating up our vasopressors here, and I like really adding in the stress dose steroids. I've seen that clinically work pretty well. A big thing here, she's very acidotic. Maybe bicarb may be something, maybe a bicarb drip may be indicated, because our vasopressors are not going to be working as well when we're that acidotic.
And then I'll just throw one last final thing in here is source control. So just if she's just, bacteremic or generalized sepsis, right? But if there is a specific nidus of infection, for example, an infected stone or an abscess or perforation, all those things we'd want to think about. So this is not the patient to, try to save money for the healthcare system. Again, if she is full code, if you're getting a CAT scan of the head anyway, probably other CAT scans, at least in my thought, might be potentially helpful here. So what happens with the patient is that here's what the provider did. Actually, they thought that it was sepsis also. And the husband actually later, when he arrived, says there's a couple of days of shortness of breath. The thought was that she would not get a CT scan because she's too unstable, just like our panel said here. And the ED diagnosis, cardiac arrest, they called at the time severe sepsis, shortness of breath, cyanosis, unresponsive. And she was admitted to the ICU. She actually did, Gavin, have that bicarbonate drip, but that could be a long discussion for another time, the role of bicarb. But at any rate, she had pressor support and anticoagulation was held. She had an echocardiogram and a deferral of her CTA. And then what eventually happened, I believe, and I don't know if I have this slide here actually, but I believe that this patient was made no code, and I believe that she did expire. So I don't have that on the slide here, but I think that's and probably not a big surprise to anyone with that. So why don't we just sort of go down? I'm going to put up the QR code here for folks who want to get CME, and then at the very end, I can put this back up here for our case next month, which is Monday, December 1st, a 12-year-old girl with syncope. And this is actually the last case of the Bounce Back book. We're going to have to find other cases for, continuing our book clubs here. But at any rate, this was a odyssey that started in 2001. So I'm going to leave this up here, and then why don't we just sort of go down our list. Roya, if you want to give us a sort of 30-second closing thought, what do you want people to take away from our discussion here tonight?
Motrin is not, ibuprofen is not, naproxen, or it is. It's all of those things. Make sure you ask the question that you want the answer from patients. Take them seriously. Differentials are everything. Consider them all, especially in these undifferentiated patients, so you're not surprised.
Gavin, what are the points you'd like people to take away from tonight?
Yeah, I think one of the big things that I really got out of this was, making sure you know why your patient's presenting and know what their baseline is, and, take those new changes into account, but also don't discredit, what their baseline is, and then, knowing why they're here, because they're obviously there for something, and you just can't get lost in the weeds and kind of anchor on one diagnosis. Just making sure you keep your differential broad.
Jordan, your thoughts?
Yeah, when you have the critical patient, I like to think of it as, unless it is absolutely medically futile or they are straight comfort care, if there is the smallest indication for something that may benefit the patient, bicarb drip, blood, whatever, do it. Because if you don't, they might die. And if you gotta do it. Yeah.
All right, awesome. And Joe?
I agree with everybody here. I will just add one small finesse detail. The antibiotic choice, I think, was excellent. I probably would have done the same, Vanc and Zosyn. But if the person is getting one antibiotic at a time, remember, Zosyn can be almost pushed. Vanc you can't get pushed, right? And obviously, later dosing of penicillins or beta lactams, we like to do extended infusions, but you want to get it into the person as soon as possible. You can't really push Vanc because of the risk of histamine release. So you don't want a Vanc going in over 60 minutes or so, and then only Zosyn afterwards, because Vanc is, again, it's great coverage for gram positives and resistance, but it's no coverage at all for gram negatives. So get your beta lactam in very rapidly first, and then the vancomycin can go in slowly afterwards, so that you make sure the person has antibiotics up front. And then, yes, you said source control. I couldn't agree more. That's another thing, that if you can, draining an abscess, pulling out an infected medical appliance. If the person has a PICC line, he thinks the source of it, get it out. I mean, honestly, it's going to save the person's life. I'm actually relatively quick to even take out people's tunnel dialysis lines. Once I'm really convinced that that's the source of it, that tunnel line, I'll take out at the bedside. So anything that you can do to actually reduce the person's load of bacteria while you're actually resuscitating them is going to be a big win.
Also, and for my point, I'm just going to actually echo one thing that Gavin said, and I think we all go in rooms, of course, when they bring in post-arrest or arrest patients, right? But there's a lot of patients that come in by a paramedic, and that might be the only person that spoke with the family at the home or spoke with someone at the grocery store that witnessed the seizure, right? So I try to really get in that room right away and see the paramedics and talk to them. I try to, nursing home patients, if I don't have adequate information, call the ECF. I try to call family members if I can, suicidal patients, etc. And sometimes it really will save your butt and actually make a big difference in the patient's outcome. So folks who have given us an hour of your time, I hope you've been worthy of it on this Monday night. To our panelists, thank you so much for your preparation and time that you spent doing this. Hopefully, we will see everyone back here next month. This is Monday, December 1st. You can sign up at embouncebacks.com, or there's also oh, here we go, a QR code that you can use to sign up for next month's Bouncebacks book club. And this next month will be the chapter 30 of our Bouncebacks critical care book. And so after that ends, we're going to find other chapters, other cases to review, because these discussions are really valuable. I've learned so much from them with the amazing folks that have been here. Anybody that missed it or wants to view things later, or the other book clubs, you can also just go back to that site. It's at the top here, embouncebacks.com. And all the book clubs, except for the very first one, are all recorded on their YouTube videos, and you can pull those up and watch them. So thank you everyone again so much, and we will look forward to see you next time. Take care, everybody.